Okay, well, let's take a look at COPD for a moment. If you look at individuals, it's a heterogeneous group, and the disease seems to present in a heterogeneous way, right? You've got rapid versus slow progression, you've got mild to severe symptoms and variability. How do you parse this all out, Byron?
Well, I think part of the problem is, I think we all agree, that for far too long we've looked at all COPD as if it's the same and treated it all the same, and that's clearly not the case. We would never at this point in time view all cancers the same, and we shouldn't be viewing all COPD the same. As you said, Peter, there are frequent exacerbators and infrequent exacerbators. There are eosinophilic exacerbators. There are more of the chronic bronchitic or bronchiectatic patients. And these subsets should deserve specific therapy aimed at them. Jim mentioned earlier lung volume reduction surgery. I mean, not all emphysema is the same. We've learned that those patients who have upper lobe predominant emphysema, if they meet certain criteria, may very well be candidates for either a surgical procedure or perhaps someday a bronchoscopic procedure that potentially can improve not only quality of life but survival. You need to look at the individuals, and we need to move away from treating them all the same, and I think that's going to be part of the focus going forward. I assume Antonio de Gold is looking at that as well.
Yeah, you know, when you take a look at COPD, and I was taught, again, when pterodactyls flew through the air, or soared, I'm not really sure what they did. I was young at the time. That COPD was COPD. And then one size fits all, here's how you treat it. That's probably been detrimental, right?
Well, I think it has been detrimental to assume that it looks the same in everyone, so you just start the same. And unfortunately, in primary care, frequently the same means you start with the same drugs you start with asthma, for example. And we really have to highlight that asthma and COPD are very different. The primary therapies are very different. And we also need to start being honest about things. The diagnosis I dislike the most is acute bronchitis. People keep having acute bronchitis. Maybe they're having exacerbations of their COPD. And so we need to be thinking, not let's just put a Band-Aid on what's happening today, but what does this mean in the context of the patient's whole course?
One of the things that, in addition to what Barbara was just saying, that has really been, I think, leading the research is the idea that people achieve a certain level of lung growth, and they come into adulthood, let's say, we'll use an arbitrary 50, and some lose lung function at a predictable rate. Others, if they smoke, lose it more rapidly. It turns out, though, that life events occurring in utero, in early life, maybe even asthma, have a profound effect on what your lung function is by age 50. So we have many people who have normal lung growth here who then smoke and lose function. And we have this other very important group who never achieved anywhere near normal lung function. So they have much less to lose, and they can have much more severe disease. We're only beginning to touch the natural history of this disease and to learn about these different patterns, and then to try to design therapies and remedies for them.
And again, I want to come back to this normalization
Correct.
Of symptoms,
Yeah.
which is that patients tend to pull back, right? And they're not going to tell you what's going on unless somebody asks them about it, right?
So Peter, the importance now is we have cohorts, we have data, we have patient information that we didn't have 20 years ago to better understand the disease. And for example, out of COPD gene, we are learning that it's probably not as important how many packs you smoke, but for how long do you smoke. We also have Uncle Joe, that he smoked, he was 90 years of age, and nothing happened with him. But you know, Uncle Joe probably had good genes, or has something else good on him.
We've all seen that story on the local news.
Right.
You know, the woman who's, it could be a man, but a woman who's 107 years old, and they say, to what do you owe your longevity? 2 packs of cigarettes and good scotch.
It's got good genes,
You know,
too.
and everyone else who did that is dead at 50.
Yeah.
But she made it.
She made it.
That's a bad role model, don't you think?
Well, but you brought up something just then, is that women and COPD, for many years, women didn't get COPD. Mainly, maybe it was because of who we studied, but women do get COPD. They get COPD at a younger age. It is more severe. It progresses more rapidly in general. And so you need to think about women in COPD as almost a phenotype, and we need to be serious about identifying those women who are just as bad as men are about, oh, nothing's going on, I'm just fine, I'm just out of shape. So,
well, if anything, in my clinical experience, women are worse.
Yes.
Because they're called upon to
Yes.
provide all of this support, and they can't admit that they can't do it because the kids got to go to school, and we got to do this, and we've
Right.
got to do that, and they're not going to give that up.
that's right, and so we need to really be very supportive.
It says, it's reminiscent of the scenario a few years ago where a group of physicians were given patient characteristics and were asked, is this asthma or COPD? I think Ken Chapman did it originally, and then Mark Miravides reproduced it in Spain. And depending on the gender, with this characteristic, if it's a man, it's COPD, and if it's a woman, it's called asthma. And so that can lead to changes. You might use a drug like a leukotriene antagonist in a woman that's not good for COPD, for example, or something vice versa. So that's, the gender is extremely important.
This is
I
fascinating.
mean, there's even some evidence suggesting that women are more susceptible to some of these,
Right.
whether they're cigarette
right,
smoke or the biomass fuels. And as Antonio was saying, the biomass fuels around the world is a staggering issue, and much of that exposure is with women and children.
You know,
And
what-
also
I'm sorry, go ahead.
their comorbidities are at a higher rate.
Higher rate, yeah.
If you have all these exposures, you are more likely also to get heart disease. Osteoporosis is certainly more common in women, especially postmenopausal, but depression and anxiety also more common in women. So the comorbidities are perhaps even more important in women.
I was trying to get at that because depression is always listed
Yes.
in all these bullet points with COPD.
Yes.
And osteoporosis
Yes.
is listed all the time in all these bullet points. And what I was trying to get at before is it causal? Is COPD causal for these two, or are they fellow travelers? Do we know?
I don't think we entirely know. I think that inflammation, as you commented on before, is very important, and it affects all these. Now, I have to believe that depression and anxiety are made worse by the symptoms and the impact of COPD on your life, in addition to the inflammatory.